Thanks, Bruce. So welcome all. Here to talk about sleep-related painful erections, just to be totally clear about it. These are my disclosures, none of them relevant to this particular presentation. I do want to acknowledge, however, I don't think anyone are in the audience right now, but some really excellent reviews. If you really want to know what's going on with this condition, I would highly recommend you check out these publications. I will refer to them during my talk, but they're worth reading in their own right. So sleep-related painful erections are a phenomenon I think we've all seen before. It was first characterized in the early 70s, characterized with this definition you see right here. Even though you'll find many case reports about it, you'll see people talking about it as caused by syndrome X, Y, or Z, there are really very few consistent associations with this diagnosis. Presents in men typically in their 40s. These men oftentimes have normal erections when they want to have intercourse, but they do have this sleep disruption, oftentimes a concomitant loss of libido that is very common in people with sleep disorders of any type. And it's very disruptive. These people have erections that will go away with the typical things, but they find waking up with these things very, very disruptive to their lives. It's worth recalling that, again, this is a normal process. Sleep-related erections have been known about for well over 80 years, and obviously most men have the experience of waking up with erections. So I think we all know that this is a normal physiological process. It's been reported since that time. They typically are associated with REM-type sleep. And a lot of this was characterized, once again, in the 70s by Erections, who really did studies of men over the course of a lifespan, identifying that while these are features that are more common in younger men, the erections are harder, they're more frequent, etc., they are characteristics of men throughout the lifespan. So they never really go away, although they might change in character over the course of a man's life. This process, to understand the pathophysiology, is worth talking about the physiology. It's tempting to speculate that these are erotic dreams. Men have erotic dreams, therefore get erections. It makes a lot of sense. However, the subsequent studies by Erections didn't really support this hypothesis. It's really more of an autonomic physiological reflex having nothing to do with mentation or arousal, at least not psychological arousal during sleep. There is plenty of evidence, and I think we've all had the experience of men who are castrated, either accidentally or as part of prostate cancer treatment, having abolition of nocturnal erections and morning erections. You really seem to have to knock it down to almost nothing, though, for this to be effective. And it can be useful in some contexts, but you really have to knock the testosterone down quite low. An interesting case report, this is an N of 1 study, but a rather interesting guy who decided he was going to go climb a mountain and wear a penile tumescence measuring device at night. So I don't know how they talked him into that, but they did. And they found that this very healthy individual had this decline in his nocturnal erections at different elevations. So there certainly seems to be an oxygen tension factor in play here for these sort of things. The real money is here, though, and ultimately, as I was saying, this is a process that seems to be somewhat autonomic and automatic. There are plenty of evidences suggesting that when men have spinal cord injury, they have less of these things going on, implying that it's a cerebral process, something going on in the brain itself. And these two particular areas that are very intimately associated with sexual response and with arousal responses have been implicated in this. Very interesting studies done about a quarter century ago looking at rats with sequential serial sectioning of the various levels of the brain. And what they determined was rats with just a brain stem still got REM sleep, but did not have sleep-related erections. Selective lesions of the lateral preoptic area of the brain did lead to abolition of sleep-related erections in these animals, but did not disrupt arousal-mediated erections, so very specific event. In a single case report, once again from 2002, a man who had compression of his LPOA also had this problem of disruption of having sleep-related painful erections related to this lesion potentially. So certainly something on the LPOA that might be important. So when do we get this transition of normal physiological process becoming a painful process? And as I said earlier, there is really no consistent pattern. You'll find plenty of case reports of a person with syndrome X having also presented with sleep-related painful erections. It's tempting to speculate that that's the cause. Maybe, maybe not. We do have this study published just this year looking at a support group. And again, I want to put a grain of salt on this paper because it is obviously a self-selected group of men with very disturbing problems that are really disrupting their lives, such that they're joining the social media support group. These men were middle-aged, kind of typical for the demographics of this condition. The majority of them really did not report any condition potentially implicatable as a cause of their SRPE, but a lot of them did have these things like sleep apnea, very common phenomenon. Many of them were using psychiatric medications or having psych disorders. Importantly, they all reported a very substantial bother of life on this 4-point or 5-point Likert scale, a bother scale of 4+ and over 2/3 of them. So these men are really, really distressed by this condition. I saw a patient just last week, in fact, who was referred to me for priapism. And I think probably many of you who've been in practice for a while have seen this referral for priapism, and you get to talk to them and you find out what's actually happening is this phenomenon of sleep-related erections, which are easily conflated. This study out of the UK, used a somewhat arbitrary distinction between the two diagnoses, but they identified men who had needed at some point an aspiration and injection procedure to reverse an erection. And they characterized those 12 men versus those men who had had prolonged and painful erections, but never reaching the point of needing this sort of intervention. When they did a series of studies on them, they found that, number one, the people with sleep-related painful erections seemed to have less tumescence, less duration of tumescence, less erection volume when they did a Doppler ultrasound. And they also had, interestingly, if you remember what the LPOA and the MPOA do, they have to do with limb movements during sleep. And so these men who had sleep-related painful erections had more limb movements, and ultimately it kind of, again, distinguishes that this particular area of the brain is the one that's relevant to this process of sleep-related erections in general. So importantly, this was not a prognostic thing, that these men who had sleep-related painful erections, as we see in our clinics on occasion, are not going to progress, at least according to this study, and I've not encountered it in my own practice, anyone who progressed to actual priapism from this condition. So how are we doing? And again, we're dealing mostly with case reports. The largest case series that I referred to earlier have 20 to 30 patients, which is pretty good, but ultimately it's not really a robust body of evidence to pull from. There are no formal guidelines, so we kind of go with what we see and what we have and what is rational. This same study, again, I mentioned it earlier, looking at these men who were in the social media support group, reported that they had been treated with a number of modalities. Satisfaction was generally low, and again, I would posit to say that these men who were still engaging with this group are the failures of treatment. This doesn't mean that everyone is going to fail at this rate with these therapies, but it does imply that there are certainly men out there for whom the therapies I will be talking about shortly do not work. So these studies here, again, highlighting what has been done, looking at this population from 2017, some characteristics of the erections on the screen there that you can look at. And the mainstay of therapy in these men was baclofen. And I think baclofen, as you know, GABA agonist. It has to do with suppression and activating GABA neurotransmission in the central nervous system. This is a neurotransmitter that's very important for the role it plays in modulating the LPOA and shutting down some of these processes. So that's really the mechanism by which we think this works, by activating GABA, suppressing some of the erection responses that would be mediated in the lateral preoptic area. These men had a pretty decent response to it. A substantial number of them did do well, but they did require prolonged therapy with this agent over a period of time. A lot of other treatments were tried, and the therapy results with this were modest at best. Side effects were not that common either, but they were not really particularly good treatments for these men. And physical therapy was turned to. I'm a big fan of physical therapy for all these pain syndromes we're talking about, but it is something that was turned to in some of these cases when all else had failed. Excuse me. An additional study here, again, different group out of the UK, looking at men once again treated with baclofen, a substantial number of them noting benefit. And this group of authors did us a service, though, by detailing all the other things that had been tried and failed. And what they determined was that antiandrogens, alpha agonists were somewhat effective. A couple of other things had failed, and they even found a couple men who had progressed to the point of having embolizations or penile prosthesis placement, and these men still had significantly bothersome pain syndrome. So really, obviously, very aggressive steps to take that did not work out for the patient's benefit. So clearly things to be avoided. So ultimately, taking this all together, this remains a very poorly understood condition. I don't think there's a cookbook or a guideline that we can put out about how to manage it. I would, however, say a substantial number of these men, as detailed in prior slides, have not had sleep evaluations. So if you're talking about a sleep disruption of any sort, get our sleep medicine colleagues involved. We've talked about it during this session. We need a multimodal, multidisciplinary team for this sort of thing, and getting a sleep specialist engaged for this sleep-related disorder is never a bad idea. You can always take your careful history, see if there is a trigger event, a trigger medication, trigger procedure, trigger injury. That certainly could lead you down the path of thinking about a neurologic entity or an anatomical abnormality. Oftentimes you're not going to find that, but obviously it's worth the exercise of finding out for sure. And then doing serum studies and nocturnal penile tumescence testing. Probably not going to get much from that, but it's not necessarily a bad idea either. In terms of therapy, according to what we came across here in the literature review, baclofen really is the mainstay of therapy because it makes sense and it has been shown to be effective. Pelvic floor physical therapy is never wrong for any pain syndrome, and pseudoephedrine, sure, you can buy it over the counter, why not give it a try, and it does have a rationale that makes sense. There is some additional evidence for tadalafil, for cinedopride, which is a serotonergic agent that is used primarily in GI applications, and then CPAP if they have a sleep disruption. Amitriptyline, again, the cure for all unexplained phenomenon, as was that I was taught when I was a resident, and I've used it many times for that. And then surgical, or not surgical, but probably medical castration for those men who really have desperate cases. These other treatments are down there. You'll see them listed. These are not things that have a very good evidence basis and carry substantial risk, so probably should be avoided. With that, thank you very much for your attention.